Hello out there, everybody in medical education land. Conrad Fisher greets you again at the beginning of our exploration of the bowels. I send you all of my best wishes, all of my goodwill through this invisible method of videotape wherever you happen to be in the world. Let us once again recommit ourselves with intensity and passion to the study of this branch of medicine, remembering something that all that you are working for, all that you are sacrificing for, all that you are making efforts for, you will achieve. You will achieve your goals, and you will help people and help yourself. Let us begin with gastroenterology again today. And I am delighted to be with you here today as we discuss something that's always been very important to me, difficulty swallowing. Therefore, dysphagia. All of the things that present with dysphagia or difficulty swallowing. Dys means difficulty, not necessarily pain on swallowing. Pain on swallowing is from the Greek word odinos, for pain, odinophagia. But dysphagia is simply difficulty swallowing, and difficulty swallowing implies that the food or the liquids get stuck in the chest as they are going down. Therefore, when all the patients have these things, they will all experience weight loss. No matter what the etiology is, they will all have weight loss. So dysphagia in general will have weight loss associated with it, so we don't have to say that over and over again for each particular type of dysphagia. They will all have weight loss because you won't gain weight when you cannot swallow. You won't gain weight when it is difficult to swallow. Therefore, dysphagia also, in general, for those of you I know who want to have all the level of intelligence and knowledge of a dorsal root ganglion and say, oh, please, Dr. Fisher, please, I don't want to have to learn too much detail because I didn't get enough oxygen at birth and I only want to learn 2 points. Dysphagia, difficulty swallowing, weight loss, barium study as the initial test, endoscopy is the most accurate test, barium study is the initial test, or manometry as the most accurate test. Therefore, no matter what the etiology is. So how would I tell that you are without the ability to relax? Kalos, without the ability to relax your lower esophageal sphincter. Why, gee, that gives dysphagia or difficulty swallowing. Well, so does cancer. That also gives dysphagia or difficulty swallowing. So how would you distinguish them? Remember our original process. The questions give you history, physical, maybe some labs, maybe not some labs. History, physical, maybe labs, maybe not some labs. And then I ask the questions, which of the following is the most likely diagnosis? What is the best initial diagnostic test? What is the most accurate diagnostic test? What is the best initial therapy? Therefore, in answering the question, which of the following is the most likely diagnosis? When would you say achalasia? Which of the following is the most likely diagnosis? Why would you say cancer? Which of the following is the most likely diagnosis? Why would you say scleroderma? For instance, what will be different in the history and physical to be able to answer each of these? A, achalasia, B, cancer, C, scleroderma. What will be different about each of these things different from diffuse esophageal spasm? Diffuse esophageal spasm of, oh yeah, I swallowed a nutcracker. I got a nutcracker esophagus. I got a nutcracker esophagus. Why would you answer that as the question, which of the following is the most likely diagnosis? We are never far from these original questions. We meditate on them. We contemplate them, and all of our studying is with these original questions. Which of the following is the most likely diagnosis? What is the best initial diagnostic test? What is the most accurate diagnostic test? What is the best initial therapy? And your favorite and mine, the most common stem, what would you do next in the management of this patient? Now, when it says do, does do mean a test or a treatment? Speak louder. Get closer to that video monitor. I can't hear you. Do next could be either a test or a treatment. What? You mean they're going to ask me to choose the difference between tests and treatments? That's the whole point. The whole point is to say, hey, does this guy taking step 2, does he know when you should get a test? Does he know when you should get a treatment? That's the whole point of the test. The whole point of the test. You ready? Conrad Fisher will now tell you the entire point. It's not that you have not heard of the tests and the treatments. It's not like you never heard of an esophagectomy. It's not like you never heard of a barium esophagram and manometry. It's not like you never heard of calcium blockers and nitrates. I feel like the weather girl here sometimes. There's actually nothing on this board. I'm just pointing to things. It's not like you never heard of calcium blockers and nitrates. The question is not whether you have heard of the tests and treatments. You ready? The main thing for both step 2 and step 3 is the order in which to do things. That is what the answer is. What comes first? What comes next? What is the order? Timing. What is the order in which to do things? That is why you have come to see me. Now, I can't seem to see you, but you have come to see me to learn the order in which to do things. That's what the book can't tell you precisely. In this circumstance, what would you do next? In this circumstance, what is the most appropriate action? In this circumstance, what is the next best step in management? Test or treatment next. Test or treatment next. What is the order in which to do things? Now, the difference between all of these, how would you answer the question, which of the following is the most likely diagnosis? Which of the following is the most likely diagnosis? Is you can't base it on difficulty. You can't base it on weight loss. You can't base it on those things. So what would be in the history and physical to say achalasia? Well, achalasia is going to tend to be in the younger person. Cancer is in the older person. Yeah, achalasia tends to be in, the question will say, the younger, non-smoker, non-drinker. Esophageal cancer will be in the older smoker and drinker. Now you might say, oh, Conrad, can't you smoke and drink and get achalasia too? You can. However, the questions are not saying the diagnosis is. The questions are saying which of the following is the most likely. So is it possible to have achalasia in a smoker and drinker? Sure. Is it possible to have cancer in a non-smoker? Sure. It's just not the most likely. It's playing the odds. Older smoker, drinker, younger non-smoker, non-drinker, because tobacco and alcohol are multiplicative. And remember, on step 2 or step 3 or any step you got, when the question says, which of the following is the most likely to result in immediate improvement in mortality, in survival? If stopping smoking is in the answer, say stopping smoking. Coronary artery disease, which of the following is most likely to result in immediate improvement in survival? Stopping smoking. Stopping your having lipids, stopping having a family history, stopping hypertension, fixing your diabetes. You are so smart. Can you say stop smoking? I thought you could. That's very good. Look at that. I can remember 3 objects at 5 minutes. Which of the following is most likely to result in immediate improvement in outcome? Which of the following is most likely to increase survival and decrease the risk of all-cause mortality? The average life expectancy for a man in the United States is about 77 or 78. The average life expectancy for a woman is about 79. Most men die before their wives. Why? Because they want to. Now, why is it that you can, the fastest way to raise survival, if everyone stopped smoking, the average for both the man and the woman would rise on average by 3 to 4 years. In other words, if all cigarettes disappeared from the United States tomorrow, the average life expectancy would be 81 or 82 for women and 79 or 80 for men. It would go up 3 to 4 years for both. Older smoker, drinker, multiplicative with alcohol. Now, what else is going to be different? Achalasia will give you dysphagia for both liquids and solids at the same time. Both liquids and solids at the same time. Am I over too far this way? Whereas the cancer will be first solids, then liquids. First solids, then liquids. And you say, how do you know that's true? I don't for sure until I have, the color-coded Dr. Fisher. History is in blue. Diagnosis is in green. Treatment is in red. How do I know for sure? Until I have the endoscopy. And the answer is, I don't know for sure. But you know what? I never saw a question that said, question 48. The diagnosis in this patient for sure is. The questions don't say the diagnosis for sure. The questions say, which of the following is the most likely? Not for sure. So, even though it may not be for sure, it doesn't have to be for sure. It just has to be probability. There is an advantage to a board test. Now, I know you don't think that there's an advantage to a board test, but there is. The advantage to the board test is, if they want you to know the answer, they have to tell you something. There's an advantage to a board test. Two things. One, if they want you to know that it's esophageal cancer, and they haven't said, the biopsy shows cancer, and they want you to know from history and physical, they'll have to tell you. It's an older smoker or drinker with dysphagia more for solids. Then over several months, the dysphagia progresses till eventually the patient has difficulty swallowing liquids as well. If they want you to know the answer, they have to tell you. Now, what's the second advantage of a board test? No matter how much pain you feel in your studying right now, this preparation is good. I hope it hurts as much as possible. Why? Because that means you're intensively studying more. Walt Whitman says, who has gone far? For I would go farther. Who has been bold and true? For I would be the boldest and truest being of the universe. Who shall sing hymns fit for the earth? For I am mad with the devouring ecstasy to sing joyous hymns fit for the whole earth. I hope it hurts because all this studying is good. And good for other people too. Okay? Don't edit that out. All right. Now, the diagnostic test for achalasia. A chest x-ray, if it's there, might show some widening of our mediastinum, okay? God didn't mean us to have an esophagus of 6 inches across of undigested bacon cheeseburgers or undigested chicken tandoori. We weren't meant to have an esophagus this wide, and it might be visible even if you're having saag paneer this wide in your esophagus. Gee, what'd you have for dinner last night? Well, I can still show you. It's right here. Now, what's the difference between that retained food from the achalasia that you can see on a chest x-ray, that you can see on a barium study, and the type of difficulty of retained food that you might see with something, say, such as a Zenker's? Now, there is a person who also has retained food. There is a person also who's regurgitating as well. There's also a person who, my favorite and yours, wakes up with undigested food particles on their pillow. Oh, that's attractive. Hi, what'd you have for dinner last night? Well, why should I describe it when I can show you? the difference between the Zankers and the achalasia is both of these people are storing up rotted food and making a compost heap inside their gastrointestinal tract. The difference is both of these people can regurgitate, but the difference between this regurgitator and this regurgitator is that this person is regurgitating one truly undigested. Okay, all right, you say, well, we're both regurgitating undigested. This person can express that food by pressing on the back of their own throat, press it out. The other thing is, Zankers is unique. I know you love it. It's the only time you woke up in the first 2 years of medical school. Zankers has someone who smells like a dog died in the back of their throat. It smells bad. Oh my God, have you been gargling with fermented donkey urine again? Zankers diverticulum. It's in there rotting like a compost heap in the back of your own throat. And that's the biggest difference here. These people don't smell so bad. Gee, you know, I'm always grateful for the things in our relationship that are advantages. Why? Because I used to date a guy who had Zankers, and you know, you both kind of regurgitate a lot, and both of you don't seem to appreciate my cooking because you're both storing it up and vomiting it up the next day. But you know, he smelled bad, and you smell kind of nice. These people smell okay, and these people smell evil. And that's the biggest difference. Then this person is able to voluntarily express the food particles by saying, gee, what'd you have for lunch? That's attractive. Time to have an internet relationship with this person. Now, achalasia, back to these, what's distinctive between these? What's distinctive? Achalasia is the person who can have a wide mediastinum on that chest x-ray. Barium studies for a person with achalasia. Here is the heart in the back of that chest. And the difference between this person and the others is that the barium study will show that the esophagus is all coming down tight to a point here. Then it bulges out, and it's like a bag in there. Now to the poetic amongst you, that looks like it coming down to a little point to you and me. It's understandable. Ekalos, without relaxation of that distal esophagus. But for the poetic, for the radiologists, they said, you know what? That sort of looks to me like a bird. Yes, there he is. And now that to them looked like a bird's beak. And since I live in a happy universe, I have to imagine that the bird is smiling. A little bird smile there. So that's a bird's beak. Now they don't really have that there, but they do have it coming down so that to the people who saw this, it looked like the little bird's beak there. Now, which of the following is the single most accurate test? Which of the following is most likely to lead to a definite diagnosis? The answer is neither one of these. The most likely diagnosis is with manometry. So manometry is the single most accurate diagnostic test. Endoscopy will be in the answer. However, endoscopy will be wrong. Rewind the tape. Endoscopy will be in the answer, but endoscopy will be wrong. Rewind. Endoscopy will be in the answer, but endoscopy will be wrong. Wrong for esophageal disorders wrong? No, honey. Wrong just for achalasia. Because the interior lining, the lumen of the esophagus, looks normal. It is not a biopsy diagnosis. The reason that endoscopy must be done for cancer is that you must have a biopsy. You must have the biopsy because you need histology. Must have a biopsy, need the histology. We don't need any histology here. We just need to see whether we have a problem with relaxation of that lower esophageal sphincter. Now, pneumatic dilation